Terrell, who are talking about a recent paper that I found really fascinating discussing financial toxicity in glioblastoma. And so, Chris, Daniel, why don't you introduce yourselves and dive right in?
Yeah.
Welcome.
Thanks for having us. I'll say I'm Chris Newman. I am faculty at Sloan Kettering as a neurosurgical oncologist, specializing mainly in spine oncology and kind of pain, but then with a research interest that's in kind of the socioeconomics of healthcare, healthcare economics, and those types of things. And a lot of this research was spurred out of my time when I was at LSU working with Danny. So, oh, and Danny, you're muted.
Classic rookie mistake. I'm Danny Terrell. I'm a chief resident at LSU Shreveport down in Louisiana. Next year, I'm going to oncology fellowship at Moffitt, which is in Tampa. And like Dr. Newman said, we worked on this when he was here, and it was very good work that we feel like we did. And we're glad that you all have invited us here.
Perfect. So that I'll share my screen and I'll start kind of taking us through stuff. So we've already introduced ourselves, but this is a project that's entirely about financial toxicity and glioblastoma, and particularly out of LSU Shreveport and the population that we served. And so we don't have any disclosures, but I think the best way to start this is by level setting a little bit and just saying, what is financial toxicity? Because it really is a term that can feel a little bit grab baggish and has a lot of different meanings. But really, when you look at the literature, it's all about the sum total of the harmful effects of healthcare related costs that are borne by both the patient and the caregiver. And the reason that we need to care about this is because all the data when we look at the fields of GYN oncology, other medical oncology fields, thoracic oncology, what you wind up seeing is that it impacts quality of life, it impacts the psychosocial well-being of the patient, and it impacts survival through the fact that people start doing things like cutting their medications in half, missing appointments, treatment non-adherence. And when we think about the fact that cancer care is getting better, people are living longer, but the cost of that is a rising healthcare cost, right? So if we look at 2020 data, it costs $200 billion for the US to actually service all the cancer patients. And there's a significant portion of that that actually is out-of-pocket expenses, and that is only going up year over year. And so being able to actually address this and understand it really is a modifiable risk factor for patient outcomes. And when we think about how we measure financial toxicity or I guess the economic contributors to it, there's the direct cost bucket and the indirect cost bucket. And direct costs are what we normally think about in terms of medications, doctor visits, imaging appointments, the actual surgery, the hospital stay, radiation treatment. But we don't talk as much about the indirect costs that go along with this, such as transportation costs, childcare costs, or even just the lost opportunity costs of going and getting your treatment where you're not at work or your caregiver is not at work, actually able to advance their career. And so that kind of gives us a sense of what is financial toxicity. But a bigger question is, how do we actually measure it, or how should we measure it? And it falls into two general buckets. There are objective measures and subjective measures. And the objective measures are very binary. And so you can think of it as bad debt. You either have bad debt that you've accumulated or you don't. You either enrolled in a payment plan to pay off your debts or you haven't. You've had bills sent to collections or you haven't. And on the opposite end, there are a lot of subjective questionnaires that people will use to try to answer this. And so there's the cost facet scale that's on the questionnaires on the right side. There's, subjective financial distress questionnaire. There's the hardship and resource distress questionnaire. And what I want to actually highlight is that when you look at these, they're very subjective about how you experience or how you feel it. They try to capture the psychosocial nature of it, right? So you get questions like, I know that I have enough money in my savings, retirements, or assets to cover the cost of my treatment. I'm satisfied with my current financial situation, or I feel financially stressed. And so these are scales that try to capture the actual psychosocial aspect of it. And if you look across the literature, no one really has said this is the best way of measuring this, or this is the best way of doing it to understand the actual impact on quality of life, survival, and any of the different measures we really care about. For the purposes of what we were doing at Shreveport, which was really kind of a pilot study looking back to understand how bad the problem is, we really focused on defining financial toxicity as bad debt. And for our purposes, what we really defined it as any charge on a patient's billing account that's severely past due. And that could be $1, it could be $10,000, it could be $20,000. And the range is quite large for the patients that we had. But we looked at this because it was very readily able to be pulled in a retrospective sense to give us a size and an idea of the magnitude of the problem, but it's also a very objective thing because we really viewed bad debt as the end result of actually having kind of the struggles with the economics. Because even if you feel financially stressed, if the result is that you were able to pay your bills, you're probably not as bad off as people who actually physically could not pay off their bills. So we really focused on this, knowing that we would probably underestimate the total number of people who might fit criteria for financial toxicity, but that this was a very good objective way of just sizing up the problem and seeing what should we do next with it. And I think before we get on to kind of the actual methods and Danny starts talking through this, I wanted to kind of paint the picture of the financial landscape of Louisiana and saying that if you look at 2022 data, the US median income is around $75,000. In Louisiana, it's around 57. But for our patient population, when we looked at the median zip code incomes of people that we are serving, it's actually around 46,000. So the people that we're kind of interacting with and taking care of are actually lower than the normal median income of a Louisianan and especially of a US citizen. And it's also worth noting that for our population, we had Medicaid expansion starting in 2016. So everyone should have some form of insurance coverage. And so with that, I'll hand it off to Danny to start walking through the study methods.
As Dr. Newman said, we designed this study to be a retrospective review of adult patients who underwent a craniotomy in our hospital for tumor resection and had a confirmed diagnosis of glioblastoma. And the years that this study is 2020 to 2022, because prior to 2020, our hospital was owned by another entity, and thus they owned the medical records from all of the time before 2020. So we started from 2020 to 2022, and we came up with 74 patients who fit this criteria. Next, we then queried the Oracle Business Intelligence Enterprise Edition, and that's the billing software that we use in our department. And so that we use that software to determine who amongst that group in box one had a bad debt discharged to their account during the time that we were taking care of them. And out of that group, 33 patients had a bad debt discharge and were deemed to be experiencing financial toxicity. And that put us at a rate of about 44%. We analyzed these two groups, the patients who did experience financial toxicity compared to the patients who did not, in a chi-square analysis. And we also did a multivariable analysis to control for any co-founders in our results. So again, you see that our rate of financial toxicity for this group was 44%, which was a little more than what we initially expected, to be honest with you. A few points that we want to highlight from factors that rose to significance was that younger patients had a higher risk of financial toxicity in our cohort. And the mean age of the patients in our group who did not experience financial toxicity was about 64.6, which essentially is 65, which we all recognize as the traditional age that one is able to be eligible for Medicare, which tends to be a little bit better coverage. And in the next slide, you'll see even in our group, Medicare patients had the lowest rate of financial toxicity compared to commercial insurance and Medicaid. We also see that length of stay increases your risk, which is a common sense kind of factor that increases the risk for financial toxicity because each night in the hospital can be anywhere from $3,000, an inpatient stay anywhere from $3,000 to $10,000. Especially when you consider that the mean debt amount was about $7,700 for our patients in this group of how much money how much bad debt was discharged. And the last and maybe most important thing some people would say is that subtotal resection. So the patients who underwent subtotal resections had higher rate of financial toxicity in our sample as well. And many studies about GBM have shown that gross total resection is beneficial to outcomes. And our study kind of goes in that vein, and we don't have the particulars of exactly why the patients in our group who received gross total versus subtotal had less rates of financial toxicity, but one can stand a reason that if you have a safe maximal resection and that you don't have any deficits, you can go back to work sooner, or you can work longer in the course of your illness, maybe compared to someone who gets a subtotal resection. The other thing that I wanted to point out about the financial details of the debt is that the average time it took for our patients in our group to experience financial toxicity or to have that first bad debt discharge on their account was about 126 days, about 4 months. And we also wanted to point out that 15 or 45% of those patients, so often they had the hospital admission was the charge that resulted in their bad debt. We also noticed in our study, and Dr. Newman mentioned a couple slides previously, that everyone in our cohort had insurance because of the early participation in Medicaid expansion that Louisiana chose to participate in. And if you look here, you can see that just because you have commercial insurance doesn't necessarily protect you from some of the negative components of financial toxicity. And it highlights that it's kind of a fallacy that we need to focus on getting everybody insurance, that if everyone has coverage, then these kinds of things won't be as much of a problem. But we can kind of see here that healthcare coverage is not the panacea. It's important and it's an obstacle if it's not there. But it did not provide the kind of protection that you would think against financial toxicity. As I said previously, the Medicare group had the lowest rate had the lowest rate of financial toxicity compared to the other two. But you can pretty much see that about 30% in each coverage group, Medicaid, Medicare, or commercial insurance, experienced financial toxicity. And that is, like we said, despite our Medicaid expansion. And that correlates with some other studies from Europe who actually have universal coverage that show that there are benefits to patients who earn more despite them having everyone having a baseline insurance coverage. So in conclusion, about 44% of our patients in this sample experienced financial toxicity, and we measured that by who incurred a bad debt. Longer hospitalizations are a significant contributor to financial toxicity, and commercial insurance was not as protective as one might think in reducing the risk for financial toxicity compared to other insurance types. We need to spend more time discussing the cost of care with our patients and better understanding it ourselves. And we mentioned that we showed the demographics for Louisiana, and our patient population is going to be very different from the patient population, say, where Dr. Newman is now in New York City, even in New York State. And so we need studies at multiple sites with higher volumes so that we can fully understand the scope of this problem.
And it goes without saying that a lot of this work takes a lot of people to help us put it together, from pulling the data, from actually analyzing the data, and helping to formulate the questions. So this is just kind of a small snippet of the team that we have that helps us really do this work and do a lot of the legwork. We just want to acknowledge all the effort they put in, both from the LSU Shreveport side and from the Sloan Kettering side. So with that, we will turn it over for a little bit of discussion.
Amazing, great work. Thanks so much for contributing. I find studies like this, truly fascinating, just kind of, unveiling this whole component of medical management and of a complex disease that we don't really consider. And also the amount of evidence supporting the gross total resection.
Yeah. It's
always surprising, right? GBM, we always say, or at least the surgeons that around here always say, it's not a surgical disease. But there's so much evidence that you really do need a gross total. Jason, Chris, if you want to start off with questions, I have one, if not.
Yeah, I have one to start. Thanks for the talk. I mean, this is really, encouraging to see people starting to think about this. We try not to live in a bubble, but I think as surgeons, we see a tumor and we want to take that tumor out at all costs, and we don't really know what happens in the patient's life sometimes. I was very interested to see the insurance rate, and then the idea that just having insurance is not a predictive measure of whether or not you end up with financial toxicity. So do you guys have an indication as to how much of it is denied charges by the insurance company and where that's really coming from? I think, if they have insurance, then where is it, what's their coverage rate? Is this just high deductibles that they can't cover? Is this billing problems between the health system and the insurer that aren't rectified by contract management that's being done properly? Where is the gap here?
Yeah, I think it's a great question. And I think the answer really is that we don't know. And retrospective studies are never going to give us that level of data, which is why Danny and I are working on kind of trying to do multi-site prospective things to kind of capitalize on the fact that we have very different patient populations, but still have very similar rates of financial toxicity. Like unpublished data says that even at Sloan, it's probably around the 35 to 40% rate for our patients. And while insurance denial and other things are going to certainly play a part in that, as well as kind of balance billing that can happen in the commercial insurance population, but not in the Medicare population, I think one of the biggest things that we do when we look at these population, these studies, is we treat insurance as a binary. It's kind of like a static factor. The same way we treat like race, age, sex as like a static thing. But realistically, when you have a GBM or a glioblastoma, and you become ill or you can no longer work, you lose your insurance. What we don't talk about in America, it's very specific and special to America for a lot of historical reasons, is that your insurance is most often tied to your job. all 5 of us get insurance through our employer. And if we become sick, we lose that insurance. And so for a lot of our patients that we're probably seeing, when they're getting sick and no longer able to actually participate in their job, they may be losing that coverage, which may actually be putting them into a different insurance bubble that we're not really fully understanding. So I think the answer is we don't really know why, but there's a lot of reasons I think that we're going to start unearthing as we start prospectively looking at this and really saying at each given point, what is a patient's insurance status? Like, where is the bad charge coming from? And like really trying to actually capture that from patients. So it's a great question that needs to be answered, but we need prospective studies. And that's one of the things that this field really is missing, to be honest.
And then to that end, how much do you think, what's your gut feeling, how much is actually the episode of hospitalization surrounding the resection and diagnosis? And how much is the radiotherapy they're getting to follow, which tends to be a big bulk of the bill that comes? And it looked like 126 days was about the time to financial toxicity. So that's in the realm of completion of external beam, right?
Yeah. I mean, Danny, do you want to start with that one, or would you like me to?
So the number of days was 126 days. But that also, and I want to kind of explain a little bit about what bad debt is here. These things are past due like 90 days. So the charge doesn't necessarily, so 120 days might be the day when they get charged from a previous hospitalization. And that hospitalization could have been surgery. It could have been a complication that required, a washout or any number of those things. So we don't have the specifics of, we know that it was a hospital admission, but we don't have a specifics of if it was they went to radiation and they were sick and then they got admitted or something like that. We do the radiotherapy in our institution is an outpatient encounter. And if we don't have the slides back up, but we only had a very few charges that were directly linked to an outpatient encounter. And that would be like a radiation or something like that. Or an infusion for chemotherapy or something like that. Those are all outpatient encounters.
Okay. Thanks.
That implies that these are surgical charges for the most part, then.
Correct.
Yeah, which I think emphasizes what Danny was saying earlier, where that longer hospital length of stay really is contributing to the actual kind of bad debt accrual. And it's important to kind of mention in that sense is that we're really just talking about kind of the initial charge that kind of is creating the bad debt. And if it's accumulating over time, like that's not going to be reflected in that individual. What is that date? And so it may be a snowballing effect that we kind of would find out from something prospective as well.
So we know that high volume centers in general have better outcomes with these diseases. But are those better outcomes overall survival or surgical outcomes like gross total resection or versus subtotal resection? Have you guys thought about looking at your high volume financial toxicity at high volume centers versus low volume centers? Or is there too many confounders, like the fact that the more complex disease is going to the high volume centers anyway, or maybe they're located in populations that are variable in their coverage? Or just financial wealth to begin with?
I mean, I think the answer is like, yes, we want to look at all that stuff. And I think we're taking a stepwise approach, right? And so what we've done kind of at LSU Shreveport, with what we're kind of now finishing off at MSK is really saying, okay, 2 different centers with 2 different patient populations, how does it look? And as we have that data, our hope is that we can start asking other centers to start looking at these same things and kind of get a very geographical swamp, because Louisiana is different than California, is different than Michigan, is different than New York, is different than Florida. To build up that data, but ultimately trying to say, yes, we want to look at high volume centers. Yes, we want to look at low volume centers. We want to see how those things matter. But I think first things first is just like actually trying to answer the question of how bad is this problem at different areas and establish baselines. Because as we start really prospectively asking some of these questions to understand it, the implicit question there is, how do we actually ameliorate this after we figure out what are the real drivers of it? So I think the answer is like, yes, we definitely need to look at high and low volume centers and see how that plays into things. And even looking at things like how does the amount of driving someone has to do to make it to that place factor into that? And really then starting to ask questions like, well, if they're going to the high volume center and they have less objective financial toxicity, but the psychosocial measures of it, right? The questionnaires show that they are under more distress. The depression screening shows that they've got higher levels of depression, or, they are struggling more with these things and their quality of life is lower despite having reasonable overall survival. Wanting to tease those things out, because driving to that great center may not always be the best thing. And I always think about this being at Shreveport was we would have people who would drive 5, 6, 7 hours to get to us for surgery. And the big downside was that that's a whole day that they are taking off where they're not making, or their caregiver is not making money. And then if they're like traveling to get good quality radiation or something else like that, it's more time that's away. And so the high volume center question is always an interesting one. I think back to a paper that came out of I think UC San Diego of like probably 5, 10 years ago, where they did a national cancer database retrospective looking at the the idea of like driving distances and saying, hey, look, like it's worth the driving distance, but it didn't really factor in the actual psychosocial or the cost of it, the socioeconomic burden. And that's what I would be wondering is how that factors into it. If you get the better resection, you may get some better overall survival, but if it's an extra 3 months, is that fiscally kind of worth whatever the psychosocial impact of that extra cost burden may be? And I don't know.
Right. Yeah, and I think that's exactly what I was thinking, Dr. Newman. As you presented this work, it's really just, I mean, it is really an incredibly thoughtful study, and I think it opens up a whole set of concepts that we frequently don't consider at the level of a neurosurgical neuro-oncologist, or frankly, probably at the level of a radiation oncologist or neuro-oncologist at the initial onset of discussions about treatment options for patients. And as we think about this, and you presented, it's a staggering number of patients who are experiencing financial toxicity when you're using a very high bar. And I would say that financial toxicity bar or percentage is even greater if you maybe used a more broad yet I would argue realistic metric about what constitutes financial toxicity. And when we think about this disease state, which is just so challenging to begin with, and then we think about the impacts it has on the patients, on their caregivers, and then you throw on, you could almost do an assessment. One, what are the factors that may be able to mitigate against this? Are there patients that we can identify early on that are likely going to experience financial toxicity and provide them additional support, writing off bad debt, providing the discussion about options for protracted payment schemes, and then moreover, even if we do extend their survival, at what cost, and is the quality of life, the emotional stressors, not just on themselves, but on as they're going through this journey, which is appropriate to manage this challenging disease entity, but also the stressors that are put upon them and upon their family. And it's very common when you talk to patients that they're worried about the implications of their disease on their caregivers, and what it does to them from an emotional standpoint. How are you going to leave them financially, especially the younger patients, which Dr. Terrell highlighted? Those are the very patients that seem to be experiencing the toxicity even more. Yeah. Oftentimes they've got kids, they've got a young family, and they have not been able to financially prepare that family for what is likely an untimely departure of that loved one because of a glioblastoma. So this to me is an incredibly impactful study, and it opens up so many different testable hypotheses and opportunities to improve care in a meaningful way. And I just don't mean overall survival or progression-free survival, which we oftentimes fixate on as clinician scientists, but really what's meaningful care to the patients and to their loved ones. And sometimes, I've heard, and Randy said about this idea of gross total resection, but managing patients with glioblastoma is not just managing the patients themselves, but managing the expectations and needs of their family and the caregivers. And I think this financial toxicity assessment really spans those, not just the patient, but maybe even more so the families and the caregivers, because let's face it, I mean, these issues don't necessarily come to an end if and when the patient passes away. They oftentimes persist in terms of credit challenges, in terms of bad debt that is not necessarily written off by some health systems, and for which they'll pursue patients, sometimes through even legal proceedings to get additional payment, even if it's pennies on the dollar. Some of these health systems will pursue that. So I commend you for this. So I know you said there's a lot of things you can do, and I'm impressed by all the things that I think in my mind popped or came to mind when you presented this. But what's next? How can we how can we take this very interesting finding and do something really impactful for patients? And I'd love to know what your next steps are.
So I think the next steps for Danny and I really are about we spent the past year or so kind of doing this same thing for a few different like patient population groups in the oncology sphere. So we've done it for the pediatric oncology space, kind of getting some interesting data there. We've done it for the spine oncology space, and it's interesting kind of where you see survival differences when you start having these very high powered types of things. But ultimately, the real goal of this is establishing baselines and trying to find partners at other sites who have different populations to really understand how this nation looks from the standpoint of this, and then trying to actually get everybody together to say, if we can identify the things that are actually the big drivers, can we start to test out hypotheses of things that might actually make it better, right? Because I look at that slide where I showed all the different ways of measuring financial toxicity, and what I really care about is, can we actually identify which one or two of those things or tests or scores or things are the actual biggest predictors of having bad outcome, be it psychosocial or overall survival, whatever it may be, and say, we're going to target this one to help people, or we're going to screen with this and see if we screen with this and identify this patient population and catch them early, can we actually make things better? I think that's the 5-year goal, is to start prospectively having like a bigger study looking at people and trying to identify ways of intervening. I think between now and then, it's going to be trying to put out a lot of data about just where do our populations stand? How bad is this problem? And the answer in neurosurgery is that a lot of it is in the 30 to 50% range. Like this data will come out hopefully in the next year, but if I look at the patients that are spine oncology patients, we see rates that are in the 40% range, and you actually see survival curves starting to separate based on the presence or absence of financial toxicity. So I think that's where this is headed in my mind.
Yeah, it's a staggering percentage. We're not talking about what I might have thought was a much lower percentage of patients. This is, and you're indicating it's not just in glioblastoma patients; it's in spinal oncology patients. I dare say it's probably in brain metastasis patients, in some sense, this is just something so important that needs to be addressed, and will have profound effects if we can address it in a meaningful way for patients and their families. I can't imagine that this alone isn't. We talk about how to extend survival by a couple months, but maybe we should be thinking about how to mitigate against financial toxicity and for the expected survival that we are getting on a standard of care currently, and that might have a greater impact in the patient's overall quality of life for the life that they've still got left.
I think it's a really great point, because it really is about shifting towards thinking about quality of life as a really big outcome measure. And, is there a point where quality of life kind of sink to where like you should start thinking differently about how you manage or do things? And really in a big way focusing on the caregiver, because we don't talk about the caregiver a lot, but they're the one who's left behind at the end, who's still grappling with it and dealing with all this stuff, and really figuring out how do we best support them during the actual cancer journey, but making sure we set them up on the back end for kind of a good life and a good quality of life after kind of this episode of care. But there's a lot of work to be done, and I think the best thing for me is that people seem to be interested in it. I've got great residents soon to be attendings, and like Danny Terrell, who want to work on it with me too. And so like I'm excited for the fact that we've got a lot of work to do, and I think we're going to make some big changes in the next 5-10 years that hopefully lead to better quality of life outcomes for patients.
Yeah.
So Chris, go ahead.
Oh, I would say from a personal experience, I can tell you that the bills that keep coming well beyond a year after an individual passes is to caregivers and their families it's just so disheartening. As you think that things are kind of behind when you take care of those end of life matters. But no, the financial toxicity and the financial bills continue well beyond that patient's survival in many instances. So, and I've heard the same from many other of my patients whose families still keep in touch with me after the fact. So, great work, really outstanding. I'm looking forward to more meaningful studies, and hopefully some of them will get published in JNO.
Hey, we'll be submitting them to you, so.
Fantastic, good. Chris,
Guys, we're at our
So
30-minute mark, Chris, but you got a question? Go ahead.
Yeah, I guess, I'll play devil's advocate here. I think, is there a chance in your mind, Chris, that potentially somebody will look at this from a purely fiscal perspective then and start saying, well, we're not going to necessarily cover certain diagnoses in the future or based upon age and different comorbidities because, in fact, we know that this is going to be a bad financial prospect. Now, personally, I don't think that's the way anything should go, and none of us here believe in that. But do you think there's a risk?
I don't think so. And I think because if you look at all like, the attempts to use prognostic tools and everything else to say who we should and shouldn't do things to, really insurance companies haven't come down starting to do those types of things. I think that in my mind, the most likely outcome of this is that we start actually saying, well, how can we have a modifiable risk factor. How can we make it better? In the same way that we do preoperative optimization for people who have, pulmonary disease, cardiac disease, anything we can do to kind of get them ready for surgery. I think that my hope is that at some point we start doing kind of prehabilitation, if you will, from essentially from it's really a modifiable risk factor of their risk of experiencing this. And I think that's where this will head. 'Cause I don't think anyone's going to ever exclude someone based on the financial side of it. But I think hopefully we have more nuanced conversation with patients going in about what things really look like. B, we connect them into social support services sooner. But C, we start trying to actually say, what are the things we can do to make this better for you long term, and really treating it as a modifiable risk factor like we would hypertension.
Yeah, I think also when you point out the bottom line of a system and you start to preemptively tell them where it's threatened, they come up with solutions that can fix that. So I think there's ways, by knowing that this is all going on, that people will take note and make efforts to kind of remedy it in a way that may be fueled by the dollar anyway, but it's still, it addresses an issue.
The interest.
Guys, we're at our 30-minute mark. Curtis, I'd love to be a part of this with you, but we're down the same street, and I know my population is your population. But I think everyone else, Jason and Chris and Danny, really a pleasure to have you guys, and we'd all love to be a part of it moving forward. It's clearly an important cause and endeavor. So thanks for being a part of Tumor Talk. We look forward to more articles.
No, thank you guys for having us. Wonderful. Take care.
Thank you very much.
Thanks.
Bye-bye.
Bye-bye.